Thank you very much for the invitation. My talk today is really going to be focused on environmental surveillance as an emerging public health tool. Just to kind of stick with the disclosure statements required, I have not had any financial relationships, although I probably should have. I feel severely underpaid in many respects. So with that, he introduced a lot of what I do, but what I did is I founded a lab here at the University of Washington called the Environmental Occupational Health Microbiology Lab. And our lab focuses on that fate, transport, detection, and control of pathogens and other microbiological threats in environmental media. So largely water, food, air, surfaces, these type of things. I'm most interested in really what happens between hosts. Okay, so what happens with the organism in its transmission route. However, for the last decade or so, our major focus has been around this idea of environmental surveillance, and we've developed a lot of different methods for a variety of pathogens. We've worked initially on polio virus. We transitioned into salmonella typhi, and then of course, once the pandemic hit, we shifted again to SARS-CoV-2, as well as a few other targets, including rotavirus, influenza, RSV, and others. I've got to mention that a lot of my time I actually spend doing essentially unpaid service work, providing leadership in this area of environmental surveillance. It is a bit of an emerging field. I've sat on the National Academy's Committee on Community Wastewater for Infectious Disease Surveillance. I have sat on the guidance group for WHO on their development of their guidance document for environmental surveillance of SARS. I've been working with NIST, which is now transitioning towards a standard methods joint task group within the standard methods group. I was leading a technical advisory committee for PATH on environmental surveillance in low and middle income countries. And most recently, I've joined an ASTHO, Ethical National Wastewater Surveillance Working Group on Infectious Disease. So it begs the question, what is environmental surveillance? And he mentioned the idea of detecting SARS in sewage, and that's really just the tip of the iceberg in terms of what we're looking at. You have to think in my field, we really do a lot of environmental monitoring for pathogens, and generally it falls into one or two different groups. We're either trying to assess and prevent an exposure, or we are trying to use a measurement from a population to understand something about the disease burden in that population. So that first part I would call largely exposure monitoring, whereas this latter I would call more the environmental surveillance. So if we were to slap a formal definition on it, I would say that environmental surveillance is ongoing and systematic sampling and analysis of wastewater and wastewater impacted surface waters for viruses, bacteria, or other microbiological targets as a composite surrogate measure of the circulation of those targets within the population. It is not a measure of exposure, and it is intended to be a supplement to clinical surveillance. Okay? It is a public health surveillance tool. Okay? You'll see these terms tossed around, wastewater-based epidemiology or wastewater surveillance. Essentially, they're meaning the same thing. Environmental surveillance is the title that was given before the SARS outbreak. So when we talked about polio, it was environmental surveillance. It was wastewater surveillance. That's all we ever measured. However, it was wastewater impacted surface waters in most cases. The wastewater-based epidemiology number really comes from the group that looks at chemical contaminants, particularly drug residues and things. And they've kind of coined that term and then tried to reappropriate the environmental surveillance world for organisms. As I said, this is a public health surveillance tool. If you look at the definition of public health surveillance, it's very similar. And the key is that it implies that the data generated is going to trip some type of public health action. And that's the piece that's not necessarily recognized. A lot of people think we're just going to go out and monitor and we're just finding information and just giving data on what's there. You've got to be able to use that data for public health action. If you look at how environmental surveillance fits within the overall surveillance ecosystem, you've got that very top level where you're looking at hospital data, deaths, all very well characterized and down to the individual level. Whereas, when we start looking at case reporting, then we've got diagnostic tests, but we have a fair rate of non-reporting, and that just gets exacerbated as we kind of work down. But ES captures pretty much all of that Pretty much anybody shedding to the wastewater system is going to be captured. And so people off sewer may not get there, but for the most part, anybody on sewer is going to get there. As I mentioned, one of the key things is how we're going to use this data. And I'll be honest, right now, that is an open question in a lot of places. We've been collecting a lot of data, and a lot of places don't know how to use it. Okay? Probably the places that are most dialed in and actively using this data are really using it mostly to inform communications to the public or to inform decision planning on resource strategy and staging. So those are really the two major issues. Initially, a lot of folks were thinking we were going to have this kind of early warning system where the bells all rang and we all started to kind of run around trying to figure out what to do. Or maybe that we were going to inform it to kind of push us towards or away from masking, some other type of intervention. But in reality, that's not really how it's been being used. I want to talk a little bit about the background and history because, again, this goes way back. You know, the folks in the wastewater-based epidemiology, I was talking with Sean earlier, they really didn't start until kind of late 80s, mid 90s in terms of looking at drug residues in wastewater as a way to track. And they coined that term wastewater-based epidemiology. But the history for microbes goes way, way, way back, really around typhoid and paratyphoid in wastewater. They suspected as early as the late 1800s that typhoid could be found in wastewater and that it might be, based on the high rate of asymptomatic carriage, it might be a conservative major. You know, it was first isolated from wastewater in Ireland by Wilson in 28, again in Edinburgh by Gray in 29, and then it just kind of kept being found. And for a while, it looked like this was going to be a routine surveillance technique. This guy in the picture in particular is Brendan Moore. He's the one that came up with something called the Moore swab. It's a fancy term, but basically it's just gauze tied to a string, and you literally soak it into the wastewater. Pretty primitive by today's standards, still pretty much the gold standard for how we look for typhoid in wastewater. So we did see this being used in the really up through the 90s, largely for outbreak investigation, but it's kind of petered off since then. We just haven't seen as much use of it. For viruses, it really goes back all the way to the late 30s, and there were two papers published in the Journal of Experimental Medicine in 1940. One that isolated polio from stool, and the second one that immediately found it in urban sewage. And if you guys recognize this picture, you probably recognize the inventors of the various vaccines, Albert Sabin and Jonas Salk, but who you may not recognize, or I suspect you wouldn't recognize, is actually John Paul and Joseph Melnick. And these two are really the father of environmental virology. They're the ones that first isolated from wastewater. Melnick was a postdoc of John Paul's. They eventually went to NIH and then left NIH, went down to Baylor, and really expanded detection of viruses in wastewater to a whole suite of other viruses, including rotavirus and norovirus. Since that time, when we first kind of identified that it's in water, the polio eradication program has really latched onto this because polio is one of these viruses that's somewhat like typhoid in that there can be a fair rate of asymptomatic carriage. And so we can have people that are not showing poliomyelitis. In fact, that's a rarity that we actually see that symptomology. And so it can circulate within a population and pose a risk. But the nice thing is that now when we look at absence of poliomyelitis, we can still go in and see if anything's in that population. Okay, and then we can follow up with SIAs. So this has been going on really since the early 2000s, but by 2018, they had 44 countries that were doing this on a routine basis and processed something on the order of about 8,000 samples a year. Okay, that sounds pretty meager relative to what we've seen now with COVID, but that's still a significant number of environmental samples and just a drop in the bucket to the 200 and some odd clinical stool samples that they process for AFP. I'll go back, I'll say one more thing. There have been a couple of other instances where WHO has kind of had the idea to try to use environmental surveillance. One is around the idea of antimicrobial resistance. They had something called the Tricycle Project, where they had certain ESBLs and colistins that they were measuring. And then they've tried to, most recently, the Gates Foundation has been trying to use it for typhoid to actually justify a Gavi application for the new conjugate vaccines. And then we came to COVID. And right off the bat, a lot of us recognized that this was likely to be in stool. SARS-1 was found in stool, found in sewage. We had good reason to believe this would be the case as well. And so we got on it, wrote the idea that we should have a collaborative around this. We did a survey of kind of what methods were out there. And as you can see from this kind of PubMed search, it started out relatively slow, but right around the beginning of that pandemic, the number of publications in and around this just skyrocketed. Okay, all those ones previously were pretty much polio and typhoid, and then it just went off the rails. So, and it wasn't just publications. What we also saw was initially there was a group that started called the COVID Poops 19, and they were basically tracking the number of dashboards and surveillance programs globally. And this is December 2020, so already getting on a year into the outbreak. And you can see they had 47 different dashboards globally that were being reported, 200 different universities engaged, 46 different countries, and 1,000 sites. You go fast forward just a year, we're at 97 dashboards. And if you go now to today, there are 195 different dashboards, 289 different universities, 72 countries involved, and just over 5,000 sampling, or 4,000 sampling sites. So here in the US, you notice a very big cluster of sites, right? Those are all pretty much falling into now something called NEWS, okay? The National Wastewater Surveillance System. This is a formal program run by CDC where they actually fund the different states to collect wastewater samples on a weekly basis or 2 times a week basis. Those numbers are then reported through a database to CDC, and CDC culminates and then reports back to the different states. CDC has also decided that they're going to expand this. They've been tossing around a number of different targets already. There are groups like Wastewater Scan, which is one of the contractors for CDC, who have already added influenza and RSV as routine sampling, but they've also started looking at adenovirus and norovirus. Okay, places like Las Vegas have been looking for Candida auris. That happens to be a particular hotspot in the community, and they found that that works well in wastewater as well. And surprisingly, Mpox is one that popped up here, and that, of course, the outbreak within the outbreak, we saw that little flare up, and it turned out that wastewater was exquisitely sensitive, literally probably picking up a single individual in a population of several 100,000. So interesting. The news panel also includes a fair number of antimicrobial resistance genes, and anybody who's read the NASEM report knows that we have some reservations about this, but it's good for maybe a baseline. But some of these really go down to where in the system that you're going to be sampling in terms of their utility. And we'll talk more about that in a moment. So where are we? So for the last 4 years, really since COVID hit, is when everything escalated. And we spent a lot of time going, can we do this? And there were literally thousands of different groups that got together and started trying different things. Some of them took off, became surveillance programs. Some of them were just kind of one-offs. But for the most part, we just wanted to know, could we do it? But we never really asked, should we do it, or why we're doing it? And these questions are really what's driving the cart now. We need to understand that there's a continued value in what we're doing for this to be a sustainable enterprise. Okay? And with expansion of these different targets, we want to make sure that there's value added along the way. So how do we do it? What does this involve? And if we look at it on the face, it's pretty simple. 3 basic steps. You get the sample, you reduce the volume of the sample down to something you can fit in a test tube, you extract the DNA, and then you amplify it either by PCR or by digital PCR. Pretty straightforward stuff, but the devil's in the details. Every one of those steps could have been a stack of dissertations in terms of trying to optimize. Okay? And again, the problem is nobody's doing it the same way right now. So we have some real issues. The other factor is that this simplicity really overlooks 2 of the most complicated pieces. One, how you get that sample in the first place. And secondly, what do you do with the data on the back end? right? And so if we're looking at the overall kind of flow of this, most of these samples and what news initially envisioned was everything would be happening at the wastewater plant. On the pipe that came in the door, you didn't have to go out and get it, it just came to you. And for targets like SARS, that probably makes some sense. But for targets that need more resolution, you might have to go out to lift stations, or you might have to go out to manholes in a particular neighborhood, or heaven forbid, go out to the lift station right behind the hospital, to try to find out and flag things. This shows the overall scope. We've got loading on the front. At the facility level, you can sample literally right outside that. It complicates things because water didn't flow quite the same way. Once you get down in the manholes, you got more steady flow, but it is diurnal. It kind of goes like this in the mornings, right? You get that first flush phenomena, and then you get the first flush when they come home. But otherwise, it's just a trickle. Then you get into the wastewater plants, pretty steady flow there, easy to collect, goes to the lab, and then we've got to figure out some way to take that data, translate it, and actually do something with it. And a lot of the focus up until now has been, let's show the public. Let's just put it on a dashboard and people have some idea what's going on, right? But the reality is they're not the ones making the decisions. They're not the ones that are going to use this data for public health action. And so we've really got to work with the public health departments to try to make sure that we're getting good use out of the data. All right, so for the next little bit, I want to kind of take some time and compare and contrast between the two best established environmental surveillance programs. That for polio, which has existed again since the early 2000s, and that of SARS, which is relatively new, but much, much bigger. Okay, and I'm going to do this in terms of 6 specific points that I want to tease out and things that we have to consider in these programs, because it really has bearing on any of the other targets we add. So the first step is the viruses themselves, right? With polio, it's an enterovirus. It's non-enveloped. It's got an icosahedral shape. It's relatively small at 27-30 nanometers. And it's got a plus sense RNA genome, right? Polio is in that enterovirus group C group, and of course is responsible for things like poliomyelitis, okay? The key thing to remember here is this high rate of asymptomatic shedding, with really only a handful of people showing up with anything significant. Really only 1 in 4 even have the flu-like illness, and somewhere in the order of 1 in 200 to maybe 1 in 2,000 actually developed the poliomyelitis. Okay, so high rates of asymptomatic spread. If you look at it, there are also 3 types of virus we have to worry about. There's the wild poliovirus, where we only have to worry about it in 2 countries, Afghanistan and Pakistan. But we have ongoing live vaccination campaigns happening in several places, and so the Sabin viruses are out there. Now you say, well, what's the problem with the vaccine virus? Well, from an environmental surveillance standpoint, it's a real issue because you're going to find it all the time. In fact, we use it as an indicator. If it's not there, something's wrong with our sample. Okay? The last one's also tricky, the CVD-PVs, and that's such a tongue tire for me. But essentially, those are vaccine-derived mutants. They're the ones that have reverted back to being very virulent. And we worry about this because it happens quite frequently with type 2. And type 2 really has been gone from the wild as a wild strain for a long time. SARS, on the other hand, is a member of the coronaviruses, the genus beta coronavirus, in the sarbecoviruses. And its big difference is that it's enveloped. And the difference is that polio, it's protein on the surface, this one's enveloped on the surface, and so that controls a little bit how it's going to partition between solids and liquid, potentially. It's going to affect the viability or the persistence of that signal. And there's some questions of whether or not the RNA persistence is going to be different, because if you pop this sucker open, the RNA becomes vulnerable. Okay? The similarities with polio are that it is a plus sense RNA genome, and that it has kind of a lot of different variants that are out there that we want to track. Second point, the prevalence. Well, in contrast to SARS, which is ubiquitous, I mean, you literally cannot take a sample right now without finding it. Okay, and I suspect it's going to be that case for quite some time. We see peaks, certainly, but in valleys, but we always pretty much can detect it in almost every sample. In contrast, polio is on the way out. In fact, we thought it would be gone by now, but it's not. And so we've seen this steep decline from the late 80s in through the early 2000s, and then it's just kind of been bobbing up along like this. And we've had some real setbacks with certain outbreaks, particularly in Africa with VDPVs, but also in Afghanistan and Pakistan. If you look at the distribution of cases for polio, it's really not very many. Certainly not, a 10% or 30% kind of prevalence at any given time. We're talking a total of maybe 6 cases in 2023 from each Afghanistan and Pakistan from the AFP standpoint. Okay, couple that though with these ones on the right-hand side where we're looking at environmental cases. They're not cases, they're samples that we took out of wastewater that happen to have polio in it, wild polio, and we could differentiate it. And so that allows us to go in and do supplemental immunization campaigns in those areas. Then you got the CVDPVs, and I don't expect anybody to read this because I can't even read it from right here. But that top bit's the type 1s, the bottom bit's the type 3s, and then all that in the middle, those are type 2s. Because we took type 2 out of the live vaccine, which was the right thing to do, but we created a naive population where there was already circulating Sabin strains sitting there, some of them reverted, and bang, we get an outbreak. Okay? Environmental surveillance has been critical to trying to track this. The sampling site and the sampling matrix. Again, location matters. And when we look at this, going back to this slide, news wants to go right from the wastewater plant. They're loath to go further up the field to get better precision, but they'll do it if it makes sense. Okay? When we start talking about polio, we're not talking about the same type of systems. In fact, we're not even really talking about wastewater in a lot of cases. We're talking about surface waters that are receiving wastewater. Okay? Drainage is directly out of the latrine. Okay, in Kibera. Rivers that are clearly highly turbid and loaded with sewage. Manholes where, surprisingly, this is in Eastleigh in Nairobi, if there's a hole in the ground, people put stuff in it. And so you got to come in and clear all the garbage out, clear the embers and fire, because they also like to light it on fire for some reason, just to be able to get in to get the sample. So a lot of logistical things for polio that you don't have to think about so much with the way we're doing our SARS-CoV-2 work. That said, they're doing it in these same locations for SARS-CoV-2 now too. The methods, and these differ on a couple of different fronts. One, I already told you, the physical nature of the virus is different between the two, and that impacts what type of methods you might want to use. For polio, there was a gold standard method. I wouldn't call it gold standard personally, but I'm maybe a little biased. It was the two-phase separation method. This method goes back literally to, I think, the 40s or 50s. It was a dextran PEG method that was used for protein separation. It works, but it was never appropriately validated for its performance. They got positive answers, and so they went with it. Okay, but they set this. WHO just decreed that this will be the gold standard. This is how you will do your environmental surveillance. And they fought and fought to hold this standard for years and years. We came up with a different approach because we recognized they were limited. They were only processing 100 or 500 mils, and then their effective volume they were actually assaying was less than 100 mils. Okay, and so we said we got to take that up because polio is getting rarer and rarer, and we need to be able to pick it up at very low levels. So we developed something called the bag-mediated filtration system. This is a collection and filtration. It basically is a giant bag, like an algae net. You can drop it into a manhole, wheel it back up. You can drop it into a river and pull it out. And then you just hook it up to a filter capsule, and it drains under gravity. Surprisingly, I can process between 3 and 6 liters as opposed to averaging something on the order of about 125 mils. Okay, so great in terms of increasing the number of volume. And then we fought with WHO and CDC for about 10 years to get this considered to be an accepted method. It's not an approved method, it is an acceptable method. And what that means is countries are now free to use it when they've got a WHO-funded program. And so this is actually used in Pakistan now as part of their surveillance system. For SARS-CoV-2, basically when it came out, everybody just went to the literature and tried every method they could think of. And it was literally 1,000 methods bloom. Our lab alone, we tried 15 different methods. And I can tell you that polio and SARS-CoV-2 do not behave similarly in any of those methods in terms of concentration. Okay, so I'm not going to say a whole lot more about this other than the fact that all of the methods give you an answer. Not all of them give you a good answer, and some of them are very hard to interpret. Next, let's talk about containment. When SARS came on the front, we've been working with wastewater for already, 90 years almost, in a situation where we had very little PPE. Some of the cases, they have labs at the wastewater plant, and they'd be a stretch to call them biosafety level 1 labs. All of a sudden, we've got SARS in the wastewater, and CDC decrees that any method concentrating wastewater requires inward airflow and respiratory protection. They made us essentially be a BSL-2 with 3 practices, or almost a BSL-3 lab. Okay, that completely changes the game in terms of who can actually do this, and drove some labs that could meet that standard to actually start pasteurizing their sample. And you can imagine that starts to introduce biases in the levels that they're reporting. Polio is not all that different in some respects in that you do have to have that additional containment, but the containment for polio is not because of the safety issue, it's about the security issue. And there's something called Gap 3, and now we're going into Gap 4, where they're tightening down the number of laboratories that can actually work with polio. And if you don't have approval and don't go through your audits, you don't get to work with it. Lastly, the use case. And this really is when we get down to the brass tacks. Why are we doing this in the first place? And with polio, there are very well cut and dried use cases. We want to use it to monitor that silent circulation, look at our progress to eradication, monitor the vaccine use, make sure that we're seeing adequate coverage that we expect, better assess elimination during outbreaks, and then document any transmission or importation for those that are at risk. Okay? We've seen good data to show that we can do all of these things. Here we are for wild polio virus. This is a comparison that BMFS versus the 2-phase method, and you can see that we get hits for wild-type polio with both methods. I think it's a little preferable for our method, but so be it. We also see that we could track the elimination of type 2 from the vaccine. On that red line, all the red boxes, I should say, have type 2 in it. That red line, vertical line between 13 and 16, that's when we took it out. You can watch it go away, and we went for like a year stretch where we had no type 2 in that system. However, it's also good because when it comes back, which it inevitably did, we could pick up in the pink boxes the CVDPV2s in both African samples as well as Pakistani samples. With SARS, it's less clear. There are a lot of potential use cases. Again, everybody wanted the early bell ringing. Then they wanted it to be able to tell how many cases were in a population. Both of those seem to be fairly elusive. We got an initial bump where we thought we were maybe 4 to 7 days advance notice, but the reality of that's very much tied to the precision and the frequency of sampling. And if you're not doing it every day, you kind of lose that edge. Okay. Now, pretty much we're using it to kind of back up our numbers because we're not seeing the same level of clinical testing or the reporting of the home rat tests, and we're using it to track different variants. Okay, and it's been very good for both of those. Really, though, it comes down to just tracking where you're at in those outbreak curves. And the big open question is, with this kind of dynamic use case shift, what's going to happen when it goes fully endemic? And if CDC does expand to these other targets, does one of the other targets all of a sudden become dominant and drive where and when we're sampling? A lot of that has to be kind of decided up front. So just to kind of wrap it up, I'm already kind of running long, I see. Several potential use cases for EAS have been dictated. And it really is going to depend, though, on which targets we decide to look for. And the one thing I will make a pleading for is that we make sure that we are considering those in advance and understanding how and what potential interactions they may have in terms of our response. Okay? We want to make sure that the methods we're using are fit for purpose. Those exist. That's probably the easiest piece for us to get to right now. The biggest issue, though, is that they are not standardized, and most of them don't have performance-based criteria defined. And so that's really the next push within NIST and WHO, is to try to push us towards more standardized methods. There are certainly still challenges and limitations that exist, but I think largely this comes down to a question of funding and how much interest we have in maintaining this. And my hope is that we don't lose interest before we actually make it useful. So we need to be able to justify the investment by doing that kind of cost-benefit analysis and truly trying to understand where environmental surveillance fits within the overall surveillance ecosystem. Okay? This whole idea of integrated surveillance is really important. Every different method we use gives us a different bit of the bigger picture. And we've got to understand what's value added, what's redundant, and how do we optimize this. That really becomes what we need to be looking at. We also need to really understand how to get that data out there and understand how to respond and establish those metrics nationally rather than having individual groups kind of dictate it. So with that, let me acknowledge a lot of my collaborators here at UW, largely in my lab, but also our collaborators at PATH, WHO, CDC, Pakistan NIH, KIMRI, University of Pretoria, Liverpool School of Tropical Medicine and Hygiene in Malawi, Emory University, Public Health England, MIT, University of Kathmandu, Stanford University, University of Virginia, ICD-DRB, and Imperial College. And that's a lot. I also want to acknowledge our people at King County we work with closely because they're the ones that give us the samples. And while it keeps coming to them, it's always a question of whether we're going to get it. So I really appreciate all the effort they give us. And of course, thank you to our funding agencies. We've gotten a lot of funding from the Gates Foundation through PATH in the past, and we've also been successful with the Population Health Initiative. So with that, thank you very much, and I will open it to any questions you might have. Please.
Thanks, that was a great talk. I have a question about how just in the field, one central problem is addressed, where if you analyze a sample and you find 1,000 copies of a pathogen, it could be one person made 1,000 or 1,000 people made one pathogen. And so how is that generally approached when you're doing these things? How are your mathematical models sort of try to address that?
Bayesian statistics. So that's the short answer. So I actually have a PhD student who's in statistics right now. He's just developed hold on for the ride. He's developed a Bayesian approach that looks at what we know the variance in shedding is coming out of stool, looks at the levels of dilution, looks at the overall sampling approach, and then tries to couple it and triangulate against clinical cases with a Bayesian model. That model we've been told, is going to be part of the Washington State overall modeling program now.
So is that how you got to the comment that you could detect one Mpox case out of 100,000?
So that's a direct quote from Lauren Hopkins in Houston, and they only found one case, but they got a positive signal at one of their plants. Now Houston's different. Houston is probably the ultimate gem of a system because they've got the same size population that we have. We have 3 plants, and each plant receives a lot of flow. They have 30 plants and like 100 and some odd lift stations that they're monitoring. So their level of precision is exquisite. And so they were able to go in and find one positive in one area and said, we got to go there.
So I have a question. I think the people here probably very much appreciate like the comments about validation and quality.
Absolutely.
And we're very highly regulated. So I was wondering, for people who are doing what you're doing, is there a regulatory agency that you have to work with? Is there what does that space look like?
Yes and no. So if you were doing a surveillance, there's a difference, research versus surveillance. Most of what we've done up until now has kind of been trying to play at both, but the reality of it is I don't do surveillance, right? State Health Lab does our surveillance in Washington. I can help them, I can consult, I can help kind of troubleshoot. But they're going to be governed by all of the public health lab requirements. And so they're going to have to meet that. If I'm going out to take samples and develop methods, I don't really have anybody I'm answering to. Initially, unless I try to commercialize a kit like I did with the polio stuff. And then I butt heads with WHO and CDC until we get it through. Yep.
So, first of all, thank you for the talk, really great one. And in the before COVID COVID days, I too came from a background in environmental micro and toxicology, and I asked myself, how come more labs were not doing what you were doing? And I asked myself, I mean, this is pretty cool. How come more labs are not doing this? And then COVID happened, and increasingly so, we're using data-driven based methodology to hopefully make a case for environmental surveillance. And so, what do you think? Like, how would you utilize that data-driven methodology to make a case for continuing these surveillance programs and initiatives?
Yeah, so I think the key really is going to come down to that cost-benefit analysis and trying to understand the role in the overall ecosystem for surveillance. If we can get at it by a cheaper method, we're going to go away, right? But the likelihood is there are going to be certain targets that we're going to have an advantage over other surveillance methods. And so it's trying to figure out which of those they are, and then if we're going to multiplex, trying to understand kind of what our hierarchy for response is. Because you can get responses that go a lot of different ways, and there may be some conflicting responses that you're going to have to address. And so best to get all that figured out. I will say that since SARS, it has been night and day difference. We used to have to kind of beg, borrow, and steal from all the laboratory and clinical folks in terms of methodologies. And since SARS hit, there are so many companies that have come out with sewage-based kits specifically for processing this. So literally, people who have never done a PCR before started doing this. And that may sound great, and we're all, yay, but it was scary because, yeah. So I mean, there's certainly there is an expertise, and I think CZC is right. If we're going to make it a surveillance program and we want it to be sustainable, it's got to be in the public health labs, or we've got to have specific requirements about who's doing it.
We have an online question. You mentioned the expansion of dashboards.
Yeah.
What information have you found to be the most useful or important to include in these dashboards? And is there anything that's been particularly valuable that maybe you wouldn't have thought of at first?
So again, I think the people that are doing it the best are probably Houston, and they've used it largely to direct communication and to direct kind of staging of resources. So going out to do a vaccine clinic or something in an area that seems to be coming up. I think that's the most useful, kind of the inward data. I'm not sure how I feel about the outward-facing dashboards. I think the public wants to be informed, and I get it. It's exciting. They want to see these curves, and they want information when we don't have clinical information that we can put out there. When hospitalizations were flat and the cases came up, then I started worrying, okay, well now the metrics aren't triangulating all that well anymore. And so it makes it a little more complicated to try to explain to the public. And so my worry with the public-facing dashboards is really just putting it out there is not enough. You've got to figure out how to craft that message so that people understand what they're looking at. And so I think it's a work in progress.
And then I have a question regarding sort of the conflict between having standardized methods and then having the ability to sort of innovate for new targets, right? So you talked about how not all targets are the same, and so looking across different surveillance methods that are maybe not optimized always for exactly the right thing. How do you kind of balance wanting to have standardized methods but being able to be nimble for when something new comes up?
Grant money. No, I mean, it's funny, but yeah, I mean, right now there are contracts to different companies to kind of develop some of these assays, but the reality is we need to keep money flowing into the areas to develop that cutting edge stuff and have it evaluated. I think there is a bit of a assumption that we're making that RNA is RNA and DNA is DNA, and it doesn't matter what organism we get it out of. If we can get wastewater, we can get that out of there and we can find it. And I think that's probably overstating our abilities drastically. But I think you've got to kind of go with that because you want it to keep going. And so you want to find ways along the way to kind of get in the margins and really improve and optimize. And I think the way is probably not full standardization, in my own opinion, the way is probably more performance-based testing and setting of standards for levels and coming up with panels for people to test, that kind of thing. Yep.
I was hoping you could comment a little bit on how you approach human subject protection and privacy, identifying one mpox patient.
So yeah, so ethics is a huge piece of this, and there are actual working groups specifically focused on it. The identifying of the one case was not identified from wastewater. The wastewater detected that there was a case in the space, and only one case then was identified via clinical surveillance. That's how they did it. For the most part, this is anonymized, and if you're collecting at a wastewater plant and you've got 300,000 people contributing to it, in theory, you could drill down deep enough and sequence the human DNA too in the same sample and maybe narrow it down. That's not what we're doing. And I think there's some real worries that people might go there with just sequence everything and sort it out. But right now, that's a far cry from what we're able to do.
So you're not doing these metagenomic, what are you doing?
So they are doing, typically if they are sequencing for these targets, it requires some level of amplification. There is so much other stuff in wastewater, right? And so just being able to get the depth to get to the targets that you're interested in, you really have got to do some type of amplification to try to get there. And so tiled-based amplification seems to be the real approach people are using. Yep.
Could you talk a little bit about Afghanistan? I mean, you mentioned these surveillance programs and your data sort of stopped. I'm surprised in 2023.
Yeah.
I mean, are we looking at catastrophic resurgence, or do we not know?
No, so that's just the GPEI data. I pulled that off their website. And so that gets updated on a monthly basis. And it's to the running year from the previous year. And so there's just not 2024 data yet.
But is there ongoing surveillance?
Oh, absolutely. Yeah. Yeah. Yeah, Afghanistan's kind of weird because it's done by Pakistan. And so it's a matter of being able to get the samples. And so they still flow and they still get them. Yeah, I don't have an active role in that anymore at all. We developed that and helped pilot it in the field with Pakistan NIH, and then they've continued to use it. PATH still has an arrangement with them where they provide troubleshooting.
Can I ask a question about the metagenomics? Has there been a documented example of variability in the genomes that you're seeing and that meaning something, or is it really just detection and quantifying?
For what?
SARS.
So a lot of the variability with SARS is about trying to identify newly emerging variants that might be a problem, and they're looking for mutations in different regions. There's one person, I think it's Mark Johnson, I think at University of Missouri or someplace. He's done a lot of trying to detangle the different things. The biggest issue with sequencing of the SARS variants is that you've got a single molecule issue. Okay, so you've got a bunch of different PCRs, and then you're using a computer algorithm to basically tease out what that alignment looks like, right? And that works fine if maybe you're in a clinical sample and you've got a limited number of quasi-species and SNPs. But when you're in a soup of wastewater, it becomes somewhat uncertain. And a lot of those variants, it's hard to kind of pin down to a single virus. And so you think you get it, you flag it, and you kind of look for emergence in the population.
All right, well, thank you very much.
You're very welcome. Thank you very much.